So our next lecture will be given by Dr. Brandon Gunn from our MD Anderson. He will talk about MD Anderson's experience at the Proton Center, Houston. So Dr. Brandon Gunn is a professor in our Department of Radiation Oncology at UT MD Anderson Cancer Center, and he's also the Center Medical Director of the Proton Therapy Center at Houston. He leads numerous research efforts and clinical trials in patient-reported outcomes, quality of life, patient symptoms and toxicity reduction, proton therapy, regressive thyroid malignancies, and he's also the radiation oncology lead of the MD Anderson head and neck cancer symptom working group. Hi, Dr. Gunn. The floor is yours. Thank you.
Thank you, Wenhua. And good morning and good afternoon, everyone. And I want to thank the UT Austin, Portugal program for the pleasure to present today. And let me start to share the screen. One second, please. Okay, quick technical check. Can you see the PowerPoint and presentation mode? Mm-hmm. Okay, thank you. Well, again, it's great to see so many participants this morning, and I hope to follow up well on Dr. Mohan's fine lecture. And, really we're going to touch on a little bit more of the clinical perspective of some of the fundamental physics and biophysical properties of protons versus X-rays that Dr. Mohan reviewed so well. And, move through the presentation with a focus on the past, present, and future of proton therapy, specifically at MD Anderson Cancer Center. And really, it can be seen here. So in the foreground of the picture on the right is our past and present. This is our Proton Therapy Center 1. And immediately behind it, connected by the sky bridge under construction that you can see, is our future. So this is will be a great technological advance in terms of proton therapy planning, imaging, delivery, and patient care in our Proton Therapy Center 2, which will be open, and we anticipate treating the first patient there in approximately 1 year. So briefly, I have no disclosures, but I am grateful and have many acknowledgements. So, this journey in proton therapy is met with many challenges over these past 16 years of our experience. An incredible team, dedicated proton professionals, our patients, our physics, dosimetry, our therapists, our clinical team members, our research staff, and then all the complexities related to ensuring patient access to proton therapy and other advanced technologies. So in general, our outline today, we're just going to touch, a brief overview, focus on the past for a moment, discuss some of the present, and really what we're trying to do in terms of clinical trials to define the value of proton therapy for all disease sites and help set the indications. And I'm going to highlight 3 particular areas of interest today: head and neck, esophagus, and pediatric ependymoma, building a little bit on what Dr. Mohan shared, and then move into the future, which will hopefully set the stage for discussions in the breakout sessions and set the speakers for tomorrow or next week's presentations rather. Okay, so why proton therapy? The rationale for proton therapy is really founded in the general principles of oncologic care and the general principles of radiation oncology in general. So we always have our eye on maximizing disease control and patient survival. And while doing that, looking for opportunities to minimize both early or on-treatment toxicities and symptoms, as well as long-term toxicities and symptoms which can be permanent. Organ preservation is always an important topic. So not only of the target tumor organ, but also the surrounding normal structures. We want to do this in order to preserve patient quality of life after we achieve the needed long-term survival. So how do we do this? The rationale and the fundamental approach for our proton therapy program from the early days has been to maximize radiation dose conformity. And we can do this now more elegantly with IMPT than any other particular modality or treatment delivery approach that we have. And then by doing this with protons, we can eliminate the unnecessary radiation, not only to the patient in general, but also to the immediate surrounding normal tissues, both immediately adjacent and around the target. And this is done through exploiting the physical and dosimetric advantages of protons that Dr. Mohan laid out. And then we're starting to understand how we can start to think about to exploit the biological advantages of protons and potentially minimize the impact on the immune system, as Dr. Mohan pointed out. So proton therapy and pencil beam scanning proton therapy, or IMPT in particular, represents a natural evolution and technological advance in radiation therapy in general. So more on the left-hand side of the screen are the important technical advances decade by decade for X-ray based treatment or photon-based treatment that led to more normal tissue protection. And this is a case of esophageal carcinoma, where we moved in the 80s, where we're treating two-dimensional therapy based upon X-ray images only, and then into the 3D era in the 1990s, and then the rapid adoption and refinements in IMRT in the 2000s and 2010s. So photon therapy has a pretty good head start in terms of technological advances, but if we turn our attention to protons, even with passive scatter proton therapy, and then more naturally with pencil beam scanning proton therapy, it's a continued advance for normal tissue protection, as shown here with reduced lung, heart, and liver dose in this esophageal case example. So Dr. Mohan showed nicely these, photons and protons are different. Protons have distinct physical properties that we exploit in the clinical realm. And we basically want to realize the full potential of this proton ability to stop, and such that there's zero exit dose beyond the target when we take a proton approach versus a photon approach, where we have this kind of exponential decay or exponential inverse square fall off of the X-ray dose distribution that can go well beyond the target and lead to unnecessary radiation. So these are physical measurements that can be made and demonstrated by our colleagues on the physics side of the house. But on the clinical side of the house, we have in vivo evidence of proton dosimetry and this zero exit dose. So on the left-hand side of the screen, these are some of the clinical observations we can see from the elimination of unnecessary radiation and the proton stopping features. So on the left is an example of a craniospinal irradiation in an adult, where the target here is the spinal canal, shown on the sagittal image of the CT on the left. The dose distributions of the passive scatter proton therapy plan with a single posterior beam treating the spinal canal. And then here we see the computer modeling and the treatment planning system of the exact dose distributions and how it stops immediately in the vertebral column with zero radiation dose to the anterior aspect of the patient, heart, lungs, liver, all pelvic and abdominal organs. And then in follow-up, we have evidence of exactly where the proton stopped, as well modeled by the proton therapy treatment planning system, where on the MRI obtained for surveillance purposes, we can see the fatty replacement of the bone marrow, which corresponds almost exactly to the distribution of the proton therapy dose and exactly where that Bragg peak was evident and the proton stopped. So this is a passive scatter example on the left, and on the right is an intensity modulated proton therapy case example. This is a case of head and neck with a tumor in the base of the tongue. This is an IMPT plan where we are able to generate these kind of steep dose gradients at the anterior aspect of the target volume with elimination of the radiation to the anterior aspect of the tongue. So on the right is the picture of the patient in the final week of radiation therapy that shows this physiologic property in real life and the biologic effect. So in the posterior aspect of the tongue, we see this whitish appearance or the confluent mucositis that we would expect for high dose radiation to the base of the tongue, and then a steep stopping of that reaction as it compares to the anterior aspect of the tongue, where we see normal mucosa, no irritations, no mucositis, and a normal glistening tongue and functioning small salivary glands in that area. And so this is really what we aim to achieve, is working off the general principle that if we don't irradiate something, you can't have a side effect in that area, as well put by Dr. Soot so many years ago. So this formed the basis for our clinical therapy program, which started in 2006. We were the first proton therapy center established in a comprehensive cancer center in the United States. And then in 2008, we were the first in North America to offer the pencil beam scanning intensity-modulated proton therapy. And then since that time, now almost 2,500 patients treated with IMPT in just that 12-year period. We are a center with 4 treatment rooms. We have many treating radiation oncologists and a dedicated staff to managing proton therapy and the proton therapy patients. So, and as Dr. Mohan mentioned, there are many subsites and age groups of patients which may benefit from proton therapy, and our clinical practice reflects that. We have a variety of patient age and disease sites treated over the years, and we'll spend a little bit of time on that in terms of the evolution of the sites for which our practice has changed. And this is where we are today. We are 4 active treatment rooms, 2 of which are standard nozzle proton therapy deliver or passive scatter proton therapy. We have 1 pencil beam scanning nozzle that is IMPT capable. And then we have 1 fixed beam line for which we're able to treat lateral fields in certain clinical situations. Generally, this is a prostate cancer indication. Our current center is outfit with KV X-ray imaging only. We have no volumetric imaging in the current center, which will be an important advance for us as we move to the second proton therapy center next year. Proton therapy is in high demand, and we operate extended hours. So we treat approximately 90 to 110 patients per day across the four treatment rooms, and often operating 18 to 20 hours a day has been our practice for the past 8 years or so to meet this demand, and able to treat about 800 patients per year. So as our program opened in 2006 and to where we are today, this reveals kind of our first decade of clinical experience and the shift in relative disease site mix. So consistent with practice at other proton therapy centers in the United States at that time, and starting with passive scatter technologies only, and then moving into more advanced delivery with IMPT, we saw a shift in the complexity and the disease sites that were managed during this first decade. So we moved from, for example, with prostate cancer patients with relative simple geometry, largely treated with passive scatter techniques as the most common disease site treated. And now today, we'll show that we have more commonly treating more complex disease sites, including head and neck, lung, pediatrics, and adult CNS. On the right shows the evolution of our delivery technique, passive scatter, and IMPT as it relates to our treatment rooms. And the red line here is the evolution of our IMPT practice in the first 10 years. So again, we came online in 2008 with IMPT with rapid implementation and adoption across the first 2 years. You'll notice that it's relatively flat here for the next 5 to 6 years, and then we see a big increase again. So this will increase we sought to increase capacity to ensure proton therapy patient access given the clinical developments and demand. And so this particular room, during this time, the hours were extended. So basically treating 5 days a week, 20 hours per day to accommodate the demand for this more advanced form of proton therapy or IMPT. This is our current mix. So this is what our disease site development has looked like at MD Anderson, leading to our current day practice, where we see that most of the patients we treat in our center today are head and neck, which represents some of the most geometrically complex patients that we manage. The majority of these are treated with IMPT. And then we also have thoracic, pediatric, CNS, and followed by GU or prostate. You'll notice some other areas that have relatively small contribution to our current clinical practice. And many of these program developments are limited by lack of the volumetric imaging and the importance of that when treating these particular sites, whether for changes in anatomic uncertainties, intrafractional motion, as Dr. Mohan pointed out, or surface image guidance, which we'll talk about in a minute. So here we were in 2006 when we opened up, and at that time there were only 4 other proton therapy centers treating patients in the U.S. and versus today, where we've had this explosion, as Dr. Mohan put it, a widespread adoption and interest in particle and proton therapy worldwide, including North America, Europe, and Asia. It's really amazing to think. So this is, just 14 years later, from 6 to 41 centers in the United States. As more centers come online and the clinical evidence builds, there's growing support within the National Comprehensive Cancer Network within the United States that proton therapy is a standard form of advanced, highly conformal radiation and has indications listed within the NCCN guidelines for the majority of sites shown here. So as we think about our current practice, our fundamental goal and our academic mission is really to define the value of proton therapy through carefully, properly conducted proton therapy clinical trials. We aim to do this for all disease sites and to set the indications for all disease sites. So there's 2 sides to this pendulum where proton therapy can be used to improve patient outcomes. On the left is proton therapy as a tool to achieve toxicity reduction, and this can be achieved in different ways, either through therapeutic de-intensification, and there are trials that look to reduce the dose or reduce the volume that we're treating, but mainly the goal of proton therapy for therapeutic de-intensification is to reduce the dose to the non-target organs or the surrounding tissues to reduce toxicity and improve patient outcomes. On the other side of the pendulum is a proton therapy approach for therapeutic intensification. So these would be for difficult to treat tumors that have poor outcomes with standard photon-based approaches or standard radiation therapy dose. And we look for proton therapy as a tool, either through escalated dose or biologic optimization to enhance the therapeutic effect at the tumor while maintaining in an isotoxic way or even reduce toxicity to the surrounding tissues. So protons to escalate versus de-intensify is the main theme in most of the trials. And here's a snapshot of the 16 active proton therapy clinical trials at MD Anderson. We're covering many disease sites, including active trials. Many of them are investigator-initiated versus cooperative group or consortium-based trials in breast, CNS, pediatrics, including adult CNS, GI, including anal cancer, GU with comparative outcomes in proton therapy, multiple trials in head and neck, sarcoma, and thoracic, both lung and esophagus. So we'll talk a little bit now about some of the clinical features of proton therapy and the clinical trials that are looking to establish the particular benefits, which we'll touch on. So this is a comparison of standard head and neck case. So this is a base of tongue cancer where the tumor on the left, where we're treating the bilateral neck. You can see the target volumes outlined in the pin colors, red, blue, and yellow. And this shows the dose distributions that are achieved with a standard IMPT plan at our institution versus an IMRT or X-ray plan in the middle, and then a subtraction of the two. And this demonstrates on the right the dose that we're able to eliminate entirely from the patient by using IMPT compared to an IMRT approach. So what we want to point out is that we think about the integral dose, in other words, that photon dose bath that can be eliminated with proton therapy. And we want to think about the tissues that we're protecting as we think about how to demonstrate the benefit, both clinically from a toxicity and a patient-reported outcomes point of view. So on the right, we can see that most of the dose that we're eliminating in this head and neck case example is anterior and posterior to the targets. And on the sagittal view in the bottom right-hand side, you can see this highlighted where we have unnecessary dose with radiation that we're able to eliminate with protons in the anterior aspect of the tongue, which is important for taste, mucositis, pain, chewing, swallowing, dry mouth. And then we have unnecessary dose from the posterior aspect of the patient, including the brain stem, spinal cord. And for these toxicities, we may be interested to think about fatigue, radiation-induced nausea and vomiting. And see, these are some of the patient-reported outcomes that we are able to focus on and try to demonstrate the clinical benefits from this dosimetric difference. So our IMPT head and neck practice was really a pioneering practice. And this was the first publication of the application of intensity-modulated proton therapy for head and neck cancer, published at the time in 2014, where we reviewed the first 15 consecutive patients treated with intensity-modulated proton therapy for head and neck cancer at our institution. And these are highly complex cases. So on the left, this is an advanced case at the base of the skull, where we have an adenoid cystic carcinoma, very difficult to treat and control radiation-resistant tumor with wrapping around critical structures such as the brainstem and the spinal cord. And we're able to see that we're able to generate a highly concave and complex dose distribution and achieve safe sparing of the underlying brainstem with resolution of tumor seen on the right-hand side. In addition to this initial experience, we focused on reporting the clinical safety, efficacy, and reduced toxicity across a number of disease sites. Within the head and neck, we recently published our first 12-year overall clinical experience showing in 600 patients, very encouraging tumor control and disease control outcomes, and low and encouraging toxicity, both acute and in the late setting. And then a number of sub-site specific studies, including periorbital tumors, nasopharyngeal carcinoma, adenoid carcinoma of the paranasal sinus, base of skull, and with a big focus on oropharyngeal carcinoma, which we'll talk about the clinical trials in that space in a second. And of course, in the head and neck, reirradiation presents unique challenges, and proton therapy is a strong consideration given the absolute obligation to minimize overlap and unnecessary reirradiation for concerns of serious toxicity. So Dr. Mohan showed this, but we have a number of comparative analyses from our institution in a matched pair way, many of them showing reduced acute toxicity. Dr. Mohan pointed out feeding tube, hospitalization, and narcotic use. We've talked a little bit about the cost of protons. No question, we have an increased upfront technical cost compared to photon-based therapy. But as we think about the value of reducing toxicities, we really need to think about the entire cycle of care. So the entire burden for the patient, entire burden for payers, hospital systems, as it relates to the treatment and management of acute and long-term toxicities. So we often focus on the upfront cost of protons, but we need to really quantify the long-term episodic care and the value of toxicity reduction that may come with proton therapy. So those are the objective outcomes: hospitalizations, feeding tubes, and narcotic use, but there's also the patient perspective. So we are interested to quantify patient-reported outcomes in a comparative way. And we know that the top symptoms for radiation therapy and chemoradiation for oropharyngeal carcinoma are not that easy to measure, but the patient needs to tell us. So the top symptoms that they report are problems with taste, dry mouth, swallowing, lack of appetite, and fatigue. And from those differences in the proton therapy distributions that I showed, we can envision for each of these, given the dosimetric differences and the doses delivered to the organs responsible for these symptoms, we can anticipate improved patient-reported outcomes. And that was shown here in these comparative results, where the total time that the patient was experiencing moderate or severe levels of these symptoms was reduced for IMPT compared to the IMRT cohort, particularly after treatment was over. So it would suggest a more rapid recovery to baseline with IMPT versus IMRT. So this laid the groundwork and some of the important statistical considerations for a randomized clinical trial. This PI of this trial is Stephen Frank. It started as a phase 2 study that rolled into a phase 3 study. So this is a randomization 1-to-1 for patients with locally advanced oropharyngeal cancer are randomized to either chemoradiation with IMPT or chemoradiation with IMRT. And exciting to report that we are now more than 400 patients have been enrolled and treated on this study. And we anticipate this study will complete accrual this spring with 440 patients enrolled and managed, with the primary endpoint being a non-inferiority progression-free survival comparison and a reduction in acute and late toxicity and other important secondary endpoints. So that was a more developed phase 3 study. We've had some questions about the role of advanced imaging and adaptive proton therapy. So this represents, on the left-hand side of that pendulum, proton therapy as an approach for therapeutic de-intensification and toxicity reduction. And the platform for this trial is to use twice weekly multiparametric MRI to guide adaptation in the treatment volume and to tailor the patient-specific tumor dose given the response characteristics and MRI parameters. So this is the MR Adaptor trial at MD Anderson. Dave Fuller is the PI. So you can see the trial therapy on the left versus the standard therapy on the right. We'll talk a little bit about the standard therapy approach in head and neck now, is that the treatment plan is designed based upon the extent of tumor at diagnosis and simulation, and it doesn't change. Regardless of the response, we still deliver this same dose to the same volume. That's the standard of care and has long been the standard for decades in our in the community. On the left-hand side is the trial therapy, where week to week, we make a volume and dose adaptation based upon the regression of the gross tumor that can be seen on the MRI, such that if the patient has a complete response by the 4th week of therapy, it will lead to a substantial reduction in the prescription dose. On the other end of that pendulum, over to the right, this is another MR-guided adaptive proton therapy approach, where for more difficult to treat tumors and tumors that are more radiation resistant. So this group is a non-HPV associated head and neck cancer, generally unresectable, with historically poor control rates with standard radiation prescription doses. So this is an MRI-guided adaptive proton therapy program looking to escalate the dose to the gross residual tumor as assessed by MRI response. And I think, this is a complex design, but in general, we're looking to escalate focal doses using proton therapy to the gross residual tumor and to try to do it in an isotoxic way, such that the dose limitations to the surrounding structures around the tumor are maintained, but using protons to give a highly focal boost strictly to the gross tumor as it continues to regress towards the end of treatment, such that we may reach doses above 80 gray in the clinical trial compared to the standard 70 gray prescription. Shifting gears a little bit to esophageal cancer, I think really this is some of the most compelling clinical evidence that we have in terms of the value of proton therapy in reducing serious life-threatening toxicities that we know exist, particularly with photon therapy and when it's used in combination with standard surgical resection in esophageal cancer, when it's as illustrated here. So on the left-hand side of the screen is the standard IMRT plan for a lower esophageal cancer. These are very difficult to treat tumors given the proximity of the esophagus to the heart, liver, lungs, and other important organs of the upper abdomen. And as many of these patients have existing comorbid conditions or will undergo surgery after completion of chemoradiation, it's imperative that we protect these cardiopulmonary structures such that we can maintain their outcomes following combined modality therapy. Dr. Mohan touched on this study, and I think, it's really compelling that we have toxicity reduction, but these are serious post-operative complications that can be life-threatening, that can be reduced with proton therapy. And this was retrospective and multi-institutional, but it really laid the groundwork and the framework for the prospective study that followed. I'll move through this quickly. It's already been shown. So the prospective study that was discussed by Dr. Mohan and completed by Stephen Lin here at MD Anderson was a randomized study of proton therapy versus intensity-modulated radiation therapy for locally advanced esophageal cancer. The total toxicity burden that Dr. Mohan described, there was substantial reduction in these toxicities. And what I think is interesting about using the total toxicity burden approach is that it really gives appropriate weight to the severity of the toxicities we're talking about. We often struggle, we give, general descriptions of high-grade toxicities, but a patient with grade 3 fatigue is very different than a patient with grade 3 cardiac event. And these have implications. And this particular scoring system, this total toxicity burden, is a very elegant way to help characterize the type of serious toxicities that can be reduced. So this positive phase 2 trial led into the ongoing phase 3 randomized trial seeking to validate those findings. And this is being conducted within the NRG cooperative group. The same design, patients are randomized to either chemoradiation with proton therapy versus IMRT. And the hypothesis and the primary endpoint is a lofty one. So based upon the superiority dosimetrically and our ability to protect those cardiopulmonary structures around the esophagus, the hypothesis in this trial is this will translate into an improved patient overall survival. So this is a high bar to reach. We can also hypothesize that the survival may be improved with protons by immune system protection, as Dr. Mohan pointed out. Dr. Lin's study showed that grade 4 lymphopenia was greatly reduced with protons compared to X-ray based treatment. And it's this combination that may lead to a demonstration of overall survival advantage for proton therapy. In terms of turning our attention now from what we know, the physical characteristics and kind of these objective and relative toxicities, now to what we think we know. So we're building the clinical evidence for the probable enhanced biological effect of proton therapy. This has been demonstrated with brain imaging changes following proton therapy, both in the pediatric example on the left, as well as the head and neck example on the right. And I think this is really probably an area of focus, and it's a reasonable first step because these are objective imaging findings. So these patients undergo routine MRI following treatment for tumor surveillance reasons. So we're able to detect imaging changes early such that we can track back to the potential nidus of the injury, for example. So if we look at the right-hand side, this outline here in red is the small area of imaging change seen in this head and neck patient following proton therapy for an advanced cancer at the sinus in the base of skull. And this imaging change is in an area where we might expect the LET or the biologic effect to be enhanced because it's at the periphery or the edge of the dose gradient achieved where the LET and end of range might be expected to be higher. And in fact, that's what we saw. So when we calculate through Monte Carlo calculation and start to look at a voxel level, we could see indeed there was an enhanced dose average LET at the periphery of the target. And the highest area was exactly where the imaging change focus began. And so in this cohort of patients that had imaging changes following proton therapy, we were able to model and demonstrate that for each given increase in LET, there was a shift to the left and the probability of risk for a given dose in terms of the risk for developing this event, which is similar shown in the pediatric example that Dr. Mohan showed. So where do we go from there? So we have the ability now through developments at MD Anderson from Win-Hua and many others in our group to manipulate and redistribute the LET in a clinically sensible way. So on the left-hand side is a LET optimized plan case example for a patient with a brain tumor. So in the upper left-hand corner is the standard dose optimization. We have a very nice distribution. The tumor is well covered, but there's nearby critical structures that we need to keep in mind. In this case, the optic nerves, optic chiasm, and the brainstem. Then if we take that same plan, where we're very satisfied with the dose distribution, considering an RB of 1.1, and we look at the LET map for that same plan, we're able to see that, in fact, just like the head and neck case example we showed, there was increase in LET in areas at the periphery of the target, and that through LET optimization, we can manipulate this, maintain the same dosimetric parameters that we expect, and also reduce the LET to important non-target structures. In this case, well demonstrated the optic structures, the brainstem, and the optic chiasm. So this really set this ability and the platform and the complexities around this set the stage for an ongoing pilot trial of LET optimized IMPT for patients with pediatric ependymoma. So the primary endpoint here will be to ensure the safety and effectiveness, the clinical adoption of a LET optimized IMPT plan, and to see if this translates into a risk reduction of developing these imaging changes as suggested by the previous models. Okay, now turning our attention to the future. So Dr. Mohan pointed out nicely some of the limitations of the previous clinical trials comparing photon and proton approaches, and it's potentially some of the limitations that we have in the active trials, is we're really comparing two technologies that are on very different trajectories. Might argue that we're nearing the full maturation of photon-based technology advances, and that we're still very much in the upward swing of the proton advances, as highlighted by Dr. Mohan so nicely. In the early 2000s, IMRT, there was rapid adoption and rapid advances, largely through institutional and advances in the vendors. And here, now we're only talking about just now, after our first 16 years, moving into a more advanced center that has photon capabilities, so to speak, where it be outfitted with the same standard technologies that we've come to expect and have become the standard of care on the photon side of the practice. So we're really looking to close this gap, and really looking to ensure that we're conducting trials and making comparisons. We want to compare the most state-of-the-art proton therapy with the most state-of-the-art photon therapy. So how do we do this? How do we close this gap? How will we realize the full clinical potential of IMPT? I think all of this really is foundational in terms of minimizing and understanding uncertainties. So Dr. Mohan pointed out nicely, the fundamental principles of proton therapy clinical care is identification and management of uncertainties. And this is really has impacts in planning, delivery, and then exploiting these biophysical properties that we've highlighted so well. There's overlap between all these columns, but I think some of the most important have to do with the application and routine use of in-room volumetric imaging and moving to real-time online plan verification and potentially to real-time online adaptive planning, such that we can deliver proton therapy plan of the day that is specific to the patient's anatomy at that given time. A number of improvements that will translate to improved dosimetric resolution and accuracy, with improvements in accelerated and delivery technology. We're using smaller proton therapy spot sizes, robust optimization. We have the potential to use multi-CT plan optimization to improve the robustness and stability of the treatment plans over time. Routine adoption of Monte Carlo dose calculation is imperative, particularly for patients with target volumes in areas of high heterogeneity. On the delivery side, much of it has to do with patient setup and volumetric imaging, management of motion, implementation of gating for patients that have a large degree of motion that we can't technically and safely manage today. And we have a large gap in the dose rate and efficiency between a photon treatment and a proton treatment. Currently, a photon treatment, the patient may be on the treatment table for approximately 10 to 15 minutes. For a complex proton plan, the treatment may take up to 45 minutes or more. So this has implications operationally, has implications for patient access and our capacity. And so an improved dose rate efficiency will not also help address that need, but also help us get to a place where we can think about routine adoption of stereotactic body proton therapy, and the implementation of proton arc therapy will be an important development as well. On the biophysical side, I'm going to move through this as Dr. Mohan went through the LET and relative biologic effectiveness topic very well. So here's what's coming for us. This is our next generation Proton Therapy Center 2, the artist rendition on the left. This will be another 4-room treatment center with implementation of volumetric imaging and cone beam CT in all 4 rooms. And then you can see on the left, the 2 rooms on the left are a little bit larger footprint. These 2 rooms will be outfit with CT on rails. We have a more compact synchrotron, and as the vendors develop applications that have a smaller footprint, they come down in cost, comes down in facilities cost. There's also availability of single room applications, and single room centers are increasingly popular, particularly in the United States. So we have our new system has been installed, and we have successfully rotated all 4 gantries this past month. And we're excited for the ergonomic features and the practical patient management in a more modern environment, which has become standard now with the newer centers as depicted, shown on the left. So much of our excitement has to do with the advances in technologies, not only improvements above what we have today, but introduction of totally brand new technologies to us in our clinical practice. We're now moving from a single room that has IMPT capabilities now to 4 rooms, which will have pencil beam scanning and IMPT capabilities. So this really represents an expansion of IMPT in the most advanced form of proton therapy. We'll have smaller spot size, improved delivery efficiency achieved through multiple mechanisms, improved delivery interfaces, which are very, very important for patient handling and operational and quality and safety considerations, and all the imaging enhancements shown on the left. So we talked about the improvement in volumetric imaging, cone beam CT, CT on rails, image registration, improved patient handling through adoption of robotic couch and 6 degree of freedom rotations, which will improve patient setup and potentially the robustness of the daily delivered treatment. So we're also excited to implement surface guided imaging in the new center, and 2 of the rooms will be outfit with surface image guidance. And this has particularly been a barrier for proton therapy application for patients with superficial targets. So in the case example shown here, this is a breast cancer patient where it's not sensical to align the patient to bony anatomy. We need to understand the soft tissue anatomy and as it relates to the treatment plan anatomy at the time it was achieved. So through application of optical surface imaging, the breast mound, arm positioning, abdomen, et cetera, can be positioned in such a way where we can ensure safe delivery of proton therapy to the superficial target. In addition, it has potentially many other applications. The patient can be tracked to ensure stability of the patient setup during treatment. It can be used as a respiratory motion management tool for breath hold or potentially other gating applications. We can monitor for patient changes. We can monitor movements of the devices within the room, such as the robotic couch motion and potentially collision avoidance to detect nozzle positioning consistent with what we would expect from the treatment plan. So our cone beam CT and our X-ray system will be a big advance for us. We're moving from a separate imaging system now to one that will be mounted on the gantry with fixed flat panels on around the treatment nozzle and detectors in the floor of the rotating gantry. This has major benefits in terms of imaging deployment time and improved throughput and reduced patient time on the treatment table. The CT on rails will be an important advance, particularly as it relates to our plan verification and adaptive CT program. So you can see in this depiction here, the CT on rail on the left-hand side of the screen, and through the robotic and articulating arm of the couch, the patient will move into the imaging position over to the left, and then the CT then slides over the patient, imaging with a diagnostic and plan quality CT that will be viable for fine detail anatomic assessments and also proton therapy plan calculation. Why is this important? We talk a lot about changing anatomy. We talk a lot about uncertainties. Many of these uncertainties we manage at the time of treatment planning, but there are many changes that we just can't account for at the time of treatment planning that we must be mindful of and ready to identify and react to ensure that we're maximizing the power of proton for that particular patient. So these come in different shapes and fashions, and they're very different depending on the disease site being treated. These are just some examples of very common interfractional anatomic changes that we encounter in our head and neck practice every day. So there's the tumor or the lymph nodes themselves can regress or even progress, such that it can impact the dose distributions and target coverage and potentially the clinical effectiveness. Patient weight loss is a very common issue across courses of radiation and chemoradiation on the head and neck, which can have profound impacts on the dose distribution. And there's other things that are very much patient specific. So many of our patients receive surgery and they may have fluid collections in the neck or other locations that can evolve and change, either increase or decrease across the course of treatment. And then importantly is the sinuses. So in the head and neck is an area of high heterogeneity, and this can change from day to day, from aeration to opacification or filling with fluid or mucosal thickening, which can impact the treatment plan. So just a couple of examples of some small changes that led to substantial impact in the treatment plan for which adaptive radiotherapy was required. So this is a patient undergoing chemoradiation for oropharyngeal cancer. On the left is the lymph node outlined in red. At the 4th week of treatment, a verification CT was obtained. The lymph node had regressed by about 30%, not tremendous, but this was in combination with about an 8% total patient weight loss at the same time. And this led to substantial degradation in the plan. So on the left was the initial plan based upon the initial CT, and on the right is the 4-week verification plan, which showed, namely, and what we observe often, is an increase in dose or heterogeneity increase, where these white clouds shown here is an unacceptable dose in an unacceptable location. So now going from a prescription of 70 gray, we now have 80 gray or higher in many sensitive areas for this particular patient. And this requires adaptive replanning. Just one other case example and cautionary tale. So this is a case example of variations that are very unpredictable and sporadic and can happen and change on a daily basis. So this is a variation in the sinus, aeration, and opacification. So this patient had surgery for a nasal cavity and sinus cancer. And this is the initial planning CT post-operatively, where you can see there's fluid levels and thickening in the sinuses. The proton therapy plan was developed and based upon this presence of these tissue densities. And then just in the first week of treatment, all of these sinus aerations, particularly in the sphenoid sinus, had resolved and the plan degraded. And this is if we had not detected this change, it could have led to significant increase in overdose to the brainstem and led to very serious life-threatening toxicity. So on the left is the plan with nice dosimetric control at the brainstem. Once this sinus aerated, we now see the overranging of the protons into the brainstem with doses exceeding tolerance. So this requires a rapid action and rapid adaptation of this particular plan. However, the current status and our current practice at MD Anderson is that we do not have the ability for rapid adaptation of the plan. All of this happens offline. So patient is treated in the treatment room. The imaging is obtained separately in our CT simulator. It takes half a day to process that plan, takes another day to evaluate the plan, If adaptation is required, it may take 3 to 5 days to develop a new proton therapy plan for delivery. So we're often left in a tough clinical decision, trying to decide whether we wait for the new plan, continue with current treatment, do back of the envelope calculations and try to estimate what the risk from that previously delivered dose might have been. And so this requires a lot of effort and manpower and careful attention to ensure safe delivery of protons, particularly in the head and neck. So what do we need? We need faster, real-time plan calculation and plan adaptation such that we can capitalize on the imaging that we obtain in a real-time way for the patient care. So really, we have a lot of existing data for the more than 12,000 patients that we treated. We can develop artificial intelligence models to mine this data to help us understand, to also inform treatment planning processes, adaptive radiotherapy processes. What changes might we predict for a given patient that we might be able to plan for upfront in a robust way? Likewise, we need the ability for rapid and reliable calculation of LET and RBE optimized plan, and could help facilitate the delivery of proton arcs. And then most importantly, I think, is this move to real-time adaptive proton planning, or RAP. So this needs to be rapidly translated into clinical practice. And I think this in particular will have the greatest impact on our future patient care. That's the challenge to all our physics colleagues on the call. So that's the end of the presentation, and I appreciate your attention, and I'm happy to have any questions now and look forward to the breakout session as well.
Thank you so much for your talk. So I have one person who sent me a question. Morgan, do you want to read it out loud?
Sure. Hi, Dr. Gunn. Thanks so much for the really interesting talk. I was wondering if you could just repeat the annual patient throughput value that you have for your current center, and then maybe comment on how you expect your new facility to compare to that, and whether or not you expect it to perform better or worse.
Yeah. Yeah. So currently we treat about 100 patients a day across the 4 rooms. We treat approximately 700 patients a year in our current setup. In the new center, this will be IMPT only center, so an IMPT expansion, and we anticipate operating all 4 of those rooms at 16 hours per day. And we anticipate to treat 30 to 32 patients per day on each machine in the new center, so approximately 120 patients a day. So this is 120 IMPT patients per day in the future versus today, where we only have 1 machine where we treat about 32 to 34 patients per day. So it's about a 4x jump in our IMPT capacity, and a slight increase in the overall daily patient census. And that's just the operational considerations in terms of operating, how we're going to operate all 4 rooms, but we anticipate 16 hours per day. Does that answer your question?
Yeah, that's great. Thanks.
Thank you. Now, Carol Lang has his hand up. Let's go for it.
Thank you very much. It's a very interesting lecture. I'm going back to the previous question that I posed about the potential role of PET or SPECT imaging in assisting in the therapy. Could you comment on that? You mentioned other imaging, but not the ones that I'm referring to.
Yeah. So this is, long been the holy grail in radiation oncology is, adaptive radiotherapy based upon response by any measure, whether it's, sophisticated imaging and PET has been tested in different ways. It has not been widely adopted. Specialized PET looking at tumor hypoxia, for example, has been of interest in the past, and using those areas, the sub-tumor volume of particular hypoxia for directed radiation therapy dose enhancement or boost is an area of active investigation, I know, in Europe. At our center, our program is largely MRI based. So we have multiple MRIs in our department that are used for MRI simulation and to support clinical trials that are looking at MRI-guided adaptive therapy. In addition, we have the MRI LINAC, or MRI Linear Accelerator. So this is a photon treatment unit where MRI imaging can be obtained during delivery and immediately before or after. So that's an area of active investigation for us. It tends to be more of MRI platform based rather than PET or SPECT based. There's also interest in MRI imaging in room in proton therapy. I think that's in development in one center, but I'm not 100% certain, but we may hear about that from other presenters. Does that get to your question? I guess my answer is our focus is MRI based rather than PET based at this time.
But you do see the advantages of, of PET and SPECT imaging.
Yes, it's been yes. I mean, as I mentioned, this is long been an area of active interest in response based radiotherapy using PET. Again, it's still considered investigational and should be considered for sure.
Thank you.
Thanks. We have another question before you, Gary. Sorry, we have someone that reached me on the chat. So Kritika, sorry if I mispronounced your name. Could you please come up with your question?
Yeah, yes. Dr. Gunn, I would like to ask you, what is your view on upright proton therapy with diagnostic CT imaging at the ISO center, as that would enable us to perform online adaptive radiotherapy, and it will be and even it can also use proton radiography if we incorporate panels on this side. So what is your view on upright proton therapy?
Well, it's not in our future plans. I know Dr. Mohan has long been a proponent of considering upright proton therapy and ring CT that can be deployed from above the patient. I think, the other question you have, it's really the concept of getting mono-isocentric treatment and imaging, right? So most of the issues with volumetric imaging and current proton system setups is that the treatment isocenter is different than the imaging isocenter, which is a barrier in terms of some of the rapid plan verification or adaptive workflows that I mentioned. Also has implications for moving the patient between imaging versus treatment position. If I understand correctly, the upright application and ring CT may be a solution to address that, where you're basically treating and imaging at the same isocenter. Hopefully Dr. Mohan's there, because I know he likes to comment on upright proton therapy and ring CT.
I think it's definitely worth considering. My favoring, but by the way, I should say that it's not for every patient, but for many patients, it may be quite appropriate and more comfortable, maybe more effective. And some studies, including one by our colleague Lawrence Court, has shown that it's quite feasible. And so I think it certainly will be less costly because there is no gantry. And it is being practiced at least at a couple of places that I know of. One of them is in Chicago. So I think it is definitely worth considering, and more centers will probably have this. And especially when you go to heavier ions, the gantries are much bigger and much more expensive. So I think it's definitely worth including that. But any center such as ours should have both at least one gantry, if not more.
Great, thank you.
Thank you for your answers, Gary. Walker, you can now and you're going to be the last one asking a question. Go for it.
Hi, Brandon. I commend you that 35% of your patients currently are head and neck. I think that's fantastic. How do you see the case mix changing? You mentioned briefly that may change when you have full IMPT.
Yeah, it's a great question, and it's interesting to look at. I'll make sure I'm unmuted. It's interesting to look at some of our kind of sister institutions and their disease site mix. Mayo Center, for example, or Mayo Clinic Proton Therapy Center, for example, their mix is very different. Breast cancer, for example, makes a large proportion of their program. They also have a large GI, upper abdomen, liver component to their program. And I think both of those programs, there's almost an absolute requirement for volumetric imaging or surface image guidance. So as we think about sites that we're not commonly treating, pelvis, abdomen, mediastinum, these are all sites that we anticipate will develop because of the availability of volumetric imaging and CT on rails in particular. So what we forecast, there will be disease site development across all sites. That being said, there will be continued interest in the existing sites today, thoracic, head and neck, certainly pediatrics, CNS. So I think that's the way we're looking at it. We hope though, for every site to have a clinical trial to try to answer those, specific questions regarding the indications or the value for that particular site. And hi, Gary.
Thank you.
Okay, so if we have no further questions, we're going to start the break now. I will split you, as I mentioned earlier, in breakout rooms. Those will be 4 breakout rooms. Just don't feel obliged to stay there. If you want to go for a walk, you can. We will be back in 30 minutes, okay? So until then, see you later.